I remember it like it was yesterday, the first day that I threw out my back. I was playing football with some friends in Baltimore. Two-hand touch, not even contact football. I'm a terrible runner, but I was on a fly route when the ball was launched into the air. Must have been a 50-yard throw, and I was way behind it. So I dug in, and I used every ounce of will and muscle that I could use to drive my body forward. Then there was a click. I can't remember if I felt it or if I heard it, but something sounded like the softened snap of two fingers. And my legs turned to jello. My momentum carried me forward as my legs crumpled beneath the weight of my torso, and I collapsed. I must have looked like I had tripped or something, because nobody came out to help me for a while, and I just lay there. The sensation of heat spread across my lower back like warm molasses. Whether I couldn't move my legs or it hurt too much to try, I just lay there, face down. I thought that was it. It's over. I broke my back. And if I didn't break my back, I'd be stuck in a wheelchair, or in too much pain to walk without using a cane. I was 21 years old. Obviously, I was over-dramatizing the situation. I got to my feet and I did walk again. And over the next week, thanks to Tylenol and a steroid shot, my pain subsided. An MRI was eventually ordered, and my doctor told me that there was mild degenerative disc disease of my lumbar spine. But I think that was just the orthopedist being nice, overcalling it to make me feel like I wasn't being such a baby about the whole thing. As a neurologist, I'll tell you that I eventually looked at those films. If my 21-year-old self were my own patient today, I would tell me just to walk it off, stretch more, do some hot yoga. But degenerative disc disease is a serious problem, and one that the general neurologist sees all the time. And distinguishing it from other disorders of the spine, or recognizing it early, can be a lot more challenging than you think. Jim Siegler here from Studio 3 in Philadelphia, and this week on the Brainwaves podcast, how bad is bad structural spine disease? When is it just arthritis and aging, and when is it something worse? We'll cover how it all happens, what it looks like when it happens, and expert recommendations on what to do when it does happen. Stay with us. If we start with a clarification on terminology, then spondylosis technically refers to nonspecific degenerative changes of the vertebral column. Such changes occur gradually over time or can rapidly follow injury, and they can result in either canal stenosis, whereby the spinal cord is compressed, or neural foraminal stenosis, in which a nerve root becomes pinched. The distinction here is clearly important, as a myelopathy and a radiculopathy produce entirely different symptoms. They're managed differently, and they can even co-occur with the general spondylotic process. Since the revolution of the MRI and the refinement of advanced neurosurgical techniques, identification and intervention of spondylotic disease is increasingly common in developed countries. In fact, cervical spondylotic myelopathy is the most common cause of spinal cord disease, period. As many as 6 in 100,000 Americans over the age of 55 suffer from cervical disc disease. Risk factors are, as you might expect, older age, male sex, back injury, and then a few other conditions like cerebral palsy, Down syndrome, and congenital narrowing of the cervical canal. Pathologically, spondylotic myelopathy occurs as a consequence of a number of unique but interrelated anatomic processes. Bony degeneration, disc protrusion, thickening of the ligamentum flavum, and cord ischemia are all thought to play a role. The problem is, with degenerative disc disease and the relationship with aging, you've really got to be looking for it. Older patients may come to your clinic complaining of generalized weakness or difficulty walking. They feel like their legs may be buckling. And your differential here will be extremely broad. Deconditioning is probably the most likely thing. Other sites of osteoarthritis like the shoulders, the hips, or the knees may also impair functioning, and almost any other systemic disease can result in fatigue or sensory motor changes, congestive heart failure, renal insufficiency, obstructive sleep apnea. And this is where your review of systems is going to be important for that initial clinic visit. Given the overall high prevalence of spondylotic disease, symptoms may vary from patient to patient. When I typically think about degenerative disc disease as opposed to other disorders of the spinal cord, it's usually because of a subacute and a progressive course of gait impairment, weakness, numbness, and maybe bowel or bladder dysfunction. But symptoms can be incredibly mild, and a patient may present with impaired dexterity of the fingertips, as you might see in a C8 radiculopathy, or bilateral foot numbness, as you might see in a thoracolumbar myelopathy. When it comes to gait dysfunction, a few features are quite specific for spinal cord disease, and they're more noticeable as the years progress. It's a characteristically spastic gait with slower speed, shorter stride length, and a wider stance due to imbalance. While bladder and bowel dysfunction are hallmarks for spinal cord disease on board exams, you see them less than 20% of the time. You might get lucky if you hear the patient complain of shooting, almost electric spine pain that runs down the arms or the legs with neck flexion, Lermit's phenomenon. And other classic findings of a myelopathy can include things like upper motor neuron signs for motor units that are below the level of the affected cord, increased tone, hyperreflexia with or without clonus, or upgoing toes or a Hoffman sign. Although in situations where there's acute cord compression, you can see entirely lower motor neuron features. In contrast to myelopathy, with foraminal stenosis, the reflexes are blunted, and the weakness is not associated with spasticity. One of my favorite examination maneuvers is the Sperling test, where you laterally flex the neck toward the affected side, or you rotate the neck in that direction, and this should narrow that neural foramen. Sometimes this can exacerbate symptoms of foraminal stenosis, but it's not a specific test for radiculopathy. Conversely, shoulder abduction, as in having the patient place their ipsilateral hand on top of their head, this should open the neural foramen and relieve symptoms. More often, I feel like people who've had neck pain or back pain and any neurologic symptoms will simply complain of pain regardless of what position I put them in or what movement they have. So none of these tests are going to be that specific, and that's why we often rely on imaging to confirm the diagnosis. When it comes to imaging, I'm not even going to waste my time talking about unenhanced CT scans. You're going to need that good quality MRI to confirm spondylotic and spinal cord parenchymal disease, and also to exclude other neurologic diseases like a syrinx or some inflammation or neoplastic process. But that doesn't mean that you always need to get that MRI. There may be a number of inconsequential incidental findings, or evidence of mild vertebral or disc disease that are wholly unrelated to a patient's symptoms. This may surprise you, but one study reported that as many as 5% of patients with ALS were originally misdiagnosed with cervical spondylosis, and those patients were treated with surgical decompression. I mean, that's just unbelievable. Obviously, they did not improve with this intervention, and it was incredibly risky for these patients. So just because somebody walked into your clinic with neck pain or hand weakness, it doesn't mean that they need a C-spine MRI. Always use your clinical judgment before taking your patient down the path that may delay an appropriate diagnosis or may result in risky and ineffective treatment. But if you think that your patient has spondylotic disease and you get that MRI, the most obvious changes are going to be T1 hypoattenuation and T2 bright signal changes in an area of the spinal cord where there is structural disease compressing the cord, which indicates cord injury. And by the time you see those changes, the injury is going to be pretty advanced. A clinical pearl here is that you should be sure that the cord is not swollen due to some intrinsic parenchymal process, like an inflammatory myelitis, and that this intrinsic swelling is causing the cord to push up against what would otherwise have been an incidental bulging disc. And I've come across a couple of cases where an older patient presents with an inflammatory myelitis at the level of a slightly herniated disc, and the bright signal on T2 in those cases was not due to cord compression by the disc. It was the inflammatory parenchymal disease responsible for cord injury. In addition to these T1 and T2 changes from cord compression, there may even be slight enhancement with gadolinium at the site of injury. And this enhancement may persist for months or even years, before and after surgical intervention. But you don't always need to see parenchymal signal changes to confirm a diagnosis of spondylosis. Like I said before, T2 brightness and T1 darkness are indicators of an advanced myelopathy. More often, patients may be symptomatic from a structural vertebral process without any cord signal change on a conventional MRI. As you would expect, the prognosis in these situations is more favorable than conditions where there is neuroimaging evidence of cord injury with T2 prolongation. In addition to the T1 and the T2 sequences, diffusion tensor imaging is becoming a more popular neurodiagnostic tool. Diffusion tensor imaging, or DTI, is really incredible because it can identify microstructural changes in neural tissue by quantifying the presence, the strength, and the directionality of water particles. and these patterns are different when there's cord compression. In patients with spondylotic disease, for example, there is reduced fractional anisotropy and increased apparent diffusion coefficient in injured regions, while the T1 and the T2 sequence can be entirely normal. In the future, DTI may play a role in identifying patients with cervical or thoracic spondylosis who may benefit from early surgical intervention before the cord injury becomes apparent on T1 or T2, and the parenchymal dysfunction is still reversible. According to one recent meta-analysis by Rindler and colleagues, published in World Neurosurgery, fractional anisotropy positively correlated with pre-surgical clinical symptoms, and its presence predicted a favorable post-operative clinical course in patients who have spondylosis. However, most of the studies identified in this meta-analysis were low quality, they lacked standard comparator groups, and they used variable outcome measures. So while the results are limited, I think they are still promising. At this time, DTI remains more of a research modality rather than a standard in routine clinical practice for these patients. If you can't get an MRI, the patient has a pacemaker or has some hardware in place, CT myelography may be useful. This is an old-school test in which contrast is injected into the thecal sac, and the patient is rotated so that the contrast can diffuse throughout the subdural space. Then a CT scan is done to evaluate how far the contrast dye has traveled, or if it's been obstructed by a spondylotic process. Not the best indicator of cord injury, as you imagine, but it's helpful in determining whether there's compression. This test is historically limited by its invasiveness and the need for iodinated contrast material. EMG can also be a useful adjunct for the identification of root disease, although nerve conduction testing is frequently normal. Often, EMG and nerve conduction studies are ordered to exclude other pathologies, like a plexopathy or entrapment neuropathy. But if there is an abnormality in nerve testing, and if it is a problem at the level of the root, you might see abnormal F-wave responses with normal distal conduction testing. Just to review what this means, the F-wave is the response to superficial stimulation of a muscle group, where the signal travels antidromically back to the alpha motor neuron in the anterior horn of the spinal column, and then a second signal circles back, orthodromically, toward the muscle fiber from that alpha motor neuron group. And this is detected by a superficial recording electrode. Because this signal passes through the nerve roots before entering and then exiting the spinal column, it could be slowed if there's significant foraminal stenosis. The H reflex, which is the nerve conduction equivalent to an ankle jerk test, can also be slowed. But it's only useful for identifying an S1 radiculopathy. So now you've made the diagnosis, MRI, EMG, or whatever neurologic testing you've done. The patient doesn't have ALS or carpal tunnel or nutritional myelopathy. They have a cervical spondylotic myelopathy. What next? Experts recommend that even in mild cases of spinal disease, non-surgical and surgical options should be considered. If untreated, as many as half of patients will clinically deteriorate over the next 5 years, so even simple interventions to reduce the risk of progression should be pursued in order to improve your patient's quality of life. Basic non-surgical options include the short-term use of a soft collar, non-opioid-based analgesic therapy including anti-inflammatory drugs or muscle relaxants, physical and occupational therapy, and obviously avoiding any high-risk activity. Surgery, as I'll discuss in a moment, is not all that reversible for patients with cervical or thoracic spondylosis, so most of the time a conservative approach can be safely considered. In patients with mild disease, according to one study, conservative non-surgical management was as effective as surgical management in patients after 3 years of follow-up. Another longitudinal prospective randomized study found no difference in several functional outcomes for patients who were treated medically or surgically for C-spine disease after 10 years of follow-up. And by this, I don't mean that the risk of deterioration over time was the same for surgery or medical arms. Patients can improve with conservative management. And I'll say that again. Patients with cervical spondylosis can improve with simple interventions, physical therapy, and pain control. So why risk back surgery if symptoms are so mild to begin with, knowing that medical therapy can be as effective? In addition to these simpler interventions, experts are going to be cautious to recommend chiropractic manipulation. I think the overwhelming consensus here is that a large number of patients find subjective benefit to neck and back manipulation and massage, but in the neurology clinic and in the hospital, we always see the cases that go completely wrong. Acute cord compression from a disc protrusion, or stroke due to vertebral artery dissection, so I typically don't recommend this in my patients. Regardless of any success with conservative intervention, early consultation with an orthopedist or neurosurgeon is not going to be the worst idea. At least the patient will have established care in the event that surgery is needed down the road, or if surgery is needed more imminently, even in the presence of mild symptoms. Compared to doing nothing, surgical intervention for spondylosis is considered cost-effective, and it can improve quality of life for most patients. Obviously, the medical fitness of the patient is a major consideration here. Preoperative evaluation by an internist or a cardiologist should be considered in patients who are at greater than minimal risk. But when should you proceed with surgery? As someone who's not a surgeon, I'm not going to admit to being an expert on this, so I'll just read what Drs. Stino and LoRusso wrote in their 2018 review article in Continuum, and you can see this referenced in the show notes. Here it is. Surgical intervention is often warranted in the setting of demonstrable weakness on examination, progression of symptoms, pain refractory to multimodality treatment, concordant spondylotic findings on imaging, and patient fitness for surgery. So basically anything besides numbness or tingling could be surgical. And there are a few different approaches to surgical intervention: anterior versus posterior approaches, minimal invasiveness, or open surgery, with guidelines that have been published in 2016 by Farrokhi and colleagues. I'm going to try my best to simplify each of these options really quickly before we wrap up. One of the lower risk, less invasive options is the posterior approach for a laminotomy or foraminotomy, for cord compression or root compression, respectively. Here the surgeon makes a small opening in the bony lamina, or in the neural foramen. Simple enough. And laminotomies or foraminotomies, or lamina-foraminotomies, are done in patients with mild symptoms due to a small disc protrusion which is compressing the cord or the neural foramina. The next level intervention would be a laminectomy for cord compression, which means removal of that bony lamina as opposed to poking a hole through it. And this can be done with or without fusion and laminoplasty. This is obviously going to be much more invasive than a laminotomy alone, and a posterior approach is again preferred. Typically, laminectomies are followed by the fusion of the spine to prevent kyphosis and instability of the spine, which usually follows when the surgeon removes part of that stabilizing bony structure. Moving on to the more aggressive techniques, the surgeon may pursue an anterior approach, which is typically going to be preferred if there's only 1 or 2 levels of cervical spondylotic myelopathy involved. The surgeon can either perform discectomy with fusion, which is removal of the herniated disc, or the surgeon can perform corpectomy with fusion, which is removal of the vertebral body. Both techniques have similar rates of success, and there are a number of different ways to remove that pathologic bone or cartilaginous material, and different ways to fuse the spine, which I'm not going to go into. As you can imagine, the procedure is going to be chosen by the surgeon on the basis of the extent of the disease and the need for stabilization following surgical repair. And with fusion after discectomy or corpectomy, results are generally pretty good when it comes to functional stabilization, but the fusion is going to significantly limit the mobility of the spine. Now, I said functional stabilization because that's usually the objective of the procedure. Surgical treatment is thought to be beneficial in that it prevents progression of the spondylotic myelopathy, not that it improves any pre-existing deficits. Although sometimes people do feel better afterwards, so keep that in mind. While stabilization of functional decline is the goal, some people don't tolerate the procedure too well. And these are typically your older patients or those with greater pre-surgical disability from their spine disease. And as I mentioned earlier, cord signal changes on T1 or T2 also predict poor response to surgical intervention, while fractional anisotropy on DTI will predict a favorable response. Well, I think that's about all that I wanted to cover in today's program, but there's a lot that we didn't have time for, like the details of surgical intervention or the specific approaches to physical therapy. We also didn't discuss the more concerning stepwise progression of symptoms in patients who have acutely herniating discs, or the issues faced by patients with ankylosing spondylitis, Chiari malformations, or Hirayama disease, which is incredibly fascinating. Hopefully we'll get to some of these topics in a future show. If you're interested, we have covered similar content in the past, things like infectious myelopathies back in episode 7, acute flaccid myelitis in children, episode 38, reflex testing in episode 76, and so on, so take a look at those. But for now, that's it for our program this week. I hope that you learned as much about this topic as I did today. The Brainwaves podcast is produced out of Philadelphia, Pennsylvania, Jim Siegler, senior producer. Music for the program this week was courtesy of Steve Combs and Scott Holmes. As always, remember this podcast is intended for medical education and entertainment purposes only. If you're using this material for a board exam, that's fantastic. But do not use this as a reference if you've got back pain, foot numbness, or if you're trying to take a patient to the operating room. Always talk to your doctor about that. And if you're a doctor, you should practice medicine using the latest guidelines and your best judgment, not an audio podcast. I'm Jim Sigler, thanks for listening.